So it's really my distinct pleasure to be introducing Dr. Tyler Bradshaw, who's a great friend and collaborator. He's an associate scientist at the Department of Radiology at the University of Wisconsin. Got his bachelor's in physics at University of Utah in 2010 and his PhD in 2015 in medical physics from University of Wisconsin, where he did a short postdoc, and then he joined the department in 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 2016. He's a certified nuclear medicine physicist through the ABS and SNM, and is also a very valuable intern in the SNMMI's Physics Instrumentation Data Sciences Council. And he's also a member of the so-called AI task force at the Society of Nuclear Medicine and Molecular Imaging. Just a really great scientist and communicator and collaborator. So it's a real pleasure to have him here, where he'll be talking to us about applications and pitfalls of AI in PET imaging. Tyler.
Great, thanks Armand. I appreciate the introduction and the invitation to present. Maybe you could also provide me a quick introduction of who is the audience? Who are you people, I guess?
Yeah, yeah, totally. So we are the Vancouver Imaging Network, and we consist of different groups focusing on medical imaging from physics, engineering, and comp-sci backgrounds. So we've pretty diverse audience, but almost everybody's on the technical side of things.
Okay.
Physics, engineering, comp-sci, medical imaging, a lot of nuclear medicine, and other kinds of medical imaging. Does that sort of cover?
Yeah, that's great. That's great. That's good to hear, so I can tailor my message and not use too many jargon words that you may not understand. So
sure.
So yeah, I'm happy to present. Actually, I wish I could come there because I love Vancouver, that area. I'm from originally Kennewick, Washington, so just south and a little bit east of where you guys are. And I used to visit that area, Vancouver. One of our favorite vacation areas is Vancouver Island, so out to Victoria. So I wish I were able to visit there, but alas, this will do until we visit there anyways, probably in the future. So first I should disclose that a lot of this work that I'm going to present is actually supported by GE Healthcare. So AI, let's talk about AI, because, well, everyone else is talking about AI, right? So if we look at, abstracts submitted to conferences, which are shown here over the years, or if we look at antmini.com, which is one of the most popular radiology websites and blogs, we look at their news events, significant news events over the last few years, everyone's talking about AI, specifically in application to radiology. So how did we get here? So I think lots of people know this, is that this new wave of AI started in 2012, because that's when Jeffrey Hinton's graduate student won the ImageNet competition using a convolution neural network. So the ImageNet is a competition where you classify images into thousands of categories like cats and cars. And they used a convolution neural network for the first time, and you can see at that arrow there where the error rate dropped significantly when they submitted their network. And then after that time, everybody has used a CNN or convolution neural network, and the errors keep dropping. So that's kind of when CNNs are, really hit became well known in the public. But really, the history of CNNs is much more nuanced. There's a lot more details to that, which is almost always the case, right? So really, the first convolution-like layer was developed back in 1980. That's where you have, convolution layers where you have shared weights in a neural network. The first CNN to use backpropagation was in '88. You can see that, a lot of these advances were incremental. It wasn't that a CNN just suddenly arrived out of the brilliance of Jeffrey Hinton, but it was much more incremental. And actually, the first CNN to win a computer vision competition was before this one was in 2012, or sorry, 2011 by Schmidhuber and his postdoc, I believe. So there's been a lot of incremental progress, and now we're kind of reaping the benefit of all the work that went into this. So the question is it really deserving of all this hype? I think it is. So I think CNNs are fantastic because what they can do is they can learn complex features. What was that?
I feel very special.
There you go. So the CNNs can learn very complex features and do complex things that would be nearly impossible to code. So think about if you were assigned the task of taking Armand's picture here and converting that into different painting for, types of painting and styles. Think about how hard you would have to work to come up with the algorithm to do that. Or even this kind of detector that's detecting a dome in an image. Think about all the problems you would encounter if you were going to hard code this into an algorithm that you're going to make up. It would be nearly impossible to do these things, or it would take so long it wouldn't be worth it. But with convolution neural networks, which are now made easy with the packages that have been developed to support them, like TensorFlow and PyTorch, you can now do these you can do these projects in weeks, months, to really tackle something that would have taken years. Now, it doesn't mean that there's no problems with them, right? So the technology, I think, is definitely better than what we had before. Is it better for us? Well, I think there's some nuances. I think there's some pitfalls. So one of the problems is developers often lack domain knowledge in which they're applying it to. So a lot of computer science people are developing and testing these algorithms in radiology and may not quite understand the need or how to do it best. For example, there was a recent Kaggle competition where the outcome, the thing that you were trying to solve, really had no clinical value. The problem overall had clinical value, but the specific task wasn't really matched to the clinical need. And that's just what happens when you don't bring in kind of the domain experts. There's also issues with replication challenges. So I know one group tried to replicate 20 different algorithms that people or architectures that people had developed, and they were only able to get 6 of those to work. So even using the people's code that they posted on GitHub, they could only get 6 out of 20 to work at all, let alone, obtain state-of-the-art results. And the other one, which, isn't talked about a whole lot, but I've experienced it, and I think a lot of people have, is that it's easy to beat the competition. Because what happens is if you're developing a new architecture, a new model, you put so much time into training that model. You might train that model 100 different times, testing different components of your model. But then you go to the competition's model and you might train that one once, right? And whatever it gives out, that's what you use. And you've fine-tuned your model 100 times comparing it to the one training you did with the competition. And so I think that produces a lot of kind of challenges in trying to compare across models. So see, these are some of the problems, kind of the big picture problems, but that doesn't mean that it's not useful. And I think it's very useful. So I'm going to talk a lot about, or all about AI in PET imaging. There's so many places you could apply AI, specifically convolution neural networks to PET imaging. So this is the subset that I'm going to talk about today. And I'm really going to focus on the first 2, which is automated image analysis and then image classification. And then I'll talk briefly about the last 2, which is PET reconstruction and attenuation correction, because I think there are some interesting aspects to those 2 problems that are worth just discussing. And as I talk, I don't know what format you usually follow, but I'm happy just, you can shout out your questions. I'm happy to field them as they come. All right, so let's get started with automated PET image analysis. So this is where we're going to take an image, we're going to apply some model, and we're going to try to measure something. We're going to try to obtain some measurements in that image. In PET, what we often do is measure what's called SUV or other metrics that essentially tell you how much disease is in the body or how much tumor there is. Okay, so PET imaging, and the application that I'm going to talk about is what we've done, and I'm going to focus mostly on what we've done in our lab, just for sake of time, because there is a lot of other people working on these problems, and I'm focus on what we've done. But we focused a lot on lymphoma. So PET imaging in lymphoma, and why did we pick lymphoma? For a couple of reasons. One is that there's a lot of data. So lymphoma patients get a lot of PET scans. And in fact, I looked at University of Wisconsin, our clinical database of PET scans, about 30% of them are for lymphoma. So there's a lot of data there. That's reason one. Reason two is that PET imaging is really important for lymphoma. It's really useful, both in staging, so when a patient first has a diagnosis and gets imaged, and then also for treatment response assessment. So after the patient gets therapy and gets another scan to see how the treatment is working. And PET is really valuable in that, in those two ways. And I'll talk more about the treatment response assessment with what's called the Deauville criteria a little bit later. But for now, I'm going to talk about the first PET scan that you would get, which is for staging or prognostication. Because one of the things that we can measure in a PET scan is what's called metabolic tumor volume. This is where we take a PET image, we contour, we draw boundaries around all the tumors throughout the body, and we measure the volume in liters of how much tumor somebody has. We also call it tumor burden. But we call it metabolic tumor volume because it's measured with FDG PET. Now, many studies have shown that this is highly prognostic. It's very useful even for risk adaptation, meaning taking patients and splitting them into different therapies based on their risk of recurrence. The problem is it's really hard to measure because it takes a long time. In our experience, it can take 30, maybe 45 minutes to measure this, which is impractical. You can't do this clinically, at least in certain ways. Now, hopefully we can make it faster and easier. And in this recent article, they talk about artificial intelligence methods may be promising in making these feasible. And that's really our goal, is to speed this up, make it reproducible so people can use it. So the study that we did is, this was a collaboration with Mount Sinai Medical School, where we had 90 patients with lymphoma, and we had their baseline FDG PET scans. This was a multi-center study that the data came from, so there were multiple scanners and institutions. And our first goal with this study was we wanted to see if we could detect disease as well as a physician. So in this case, we were going to split up. Ultimately, we want to measure disease, but we wanted to split it up into tasks. So the first step is to detect disease. And this study just got published online last week, I believe, in Radiology AI. And I should mention that Amy Wiseman in the corner here was the graduate student who did this work, and she has since graduated. But yeah, so we had 90 patients, and we had physicians go through and label the images. So this is what they look like down here. We had one physician label all 90, and then a second physician label a subset of 20 patients. And that way we could get the kind of an idea of how the different physicians agree or disagree. And we could try to, that would then become our target. We'd want to get our model to get as close to the physician as the two physicians are together with each other. So this is what the labeling process looks like. It's drawing those contours in the patient.
Can I shoot a quick question at you?
Yeah.
So when the physicians delineate the tumors, do they delineate every tumor in the images or just a subset of tumors per image?
Yeah, it's a good question. Every tumor, the goal is to delineate every tumor. Now that's complicated, and I'm going to talk about it in a little bit, because there are tumors that are hard to delineate, like in the bone marrow, spleen. Some of those tumors are hard to delineate. But the goal was to delineate all the tumors.
Okay, thank you.
Yeah. And as you can see, there's a lot of disease. Lymphoma does not, often spreads throughout the body. It's heterogeneous. I will say that these physicians, even though they were eager to participate at the start, were not so eager to continue participating at the end. It was a lot of work. it was a lot of work, and it was kind of mind-numbing to try to go through all these patients and label the disease. So we use those labels and the images, PET and CT images, as inputs to a 3D convolution neural network. This is the network that we used, and this is, I really like this network when came out several years ago, but it's been really powerful for us, especially when we compare it to other ones. It's called Deep Medic. It actually is 3D patches. It takes 3D patches and almost like in a raster method, scans across the image, but it takes multiple resolution pathways. So it zooms in and then zooms out and then zooms out, and then it combines the different pathways at the end and assigns a label. So we use this network. We actually use an ensemble of 3 of these networks trained for the same task and then combined at the end. And we did 5-fold cross-validation. And these are the results we got. So
Tyler, what does combining mean exactly at the end?
Yeah, so we did a majority vote. So we have 3 networks. So every pixel was
Got it.
You know, has a segmentation mask, and then we did a majority vote for which one would be included.
But so on inference, then you're using output from all of them.
Yes.
Okay.
Yes. Yep. Yeah, and I'll show you why when I get to the result on the next slide, I believe. So here are the results that we got. So the green represents true positives identified by the network. The red is a false positive, meaning the network identified a region that's not disease. And the blue is where the network missed disease, so a false negative. And you can see we got pretty good results. The outliers are these bottom 2 right here. And those are patients, I think they're the only 2 patients that had brown fat uptake. This is a phenomenon in PET where there's a minority of people have brown fat, and it's located in their shoulders and sternum, and that gets activated and takes up a lot of FDG, and it kind of makes the picture messy and it's hard to interpret, but it confused our algorithm clearly, and it's mostly because we only had a few patients that had brown fat uptake. When we get to the quantitative results, you can focus on this top left one. So what we have here is the red is a single CNN trained on 90 patients, or evaluated and trained on the 90 patients. Then the black is where we do 3 CNN, so an ensemble. And you can see we clearly get better results. And then what's also shown here is the star, which is the physician's agreement. So what this shows is that physician 2 found about 95% of the lesions that physician 1 found, but in addition, about 3.5 additional lesions per patient. So this is, I should say, the x-axis and the y-axis here. The x-axis is number of false positives per patient, and then the y-axis is the sensitivity.
So the N20 versus N90?
So that's the subset that the second physician segmented.
I see.
So 90 was segmented by 1, and then 20 was segmented by 2 physicians. Mm-hmm. And so what you can see is this star is essentially our goal, is to try to get to that star. And what we got was this dotted line in that subset of 20 patients, and we almost got there, right? So we're not perfect for sure, but it's pretty encouraging that we're almost to the level of interphysician agreement or disagreement. I hope that makes sense. It's a little hard to present that, but that's kind of the target. And then here it shows individual patient performance, where each dot represents the number of patients that had this level of sensitivity and number of false positives. So you can see the average patient, we had about 100% sensitivity and a few false positives. And then the bottom ones just show that we did better in small lesions big lesions with high uptake. The small ones with low uptake, we did worse in. All right, so those are results, but I like to talk about pitfalls. And I'm gonna talk a lot about pitfalls in this talk because I think it's good to discuss them, to kind of disclose the problem areas, the things that people are gonna struggle with. So the pitfalls in this detection problem was labeling. Physician labeling, consistent labeling is hard. It really is. So we even had our 2 physicians help us come up with our guidelines for labeling. They did the first patient together. And then by the end, they had kind of diverged a little bit on how they treated things. And it's not their fault. It's just that this process is not part of clinical care, right? It's very easy for them to see a huge mass in the thorax and then ignore small, tiny nodes right next to it because those are inconsequential. But if you're training an AI algorithm, you don't want the AI algorithm to ignore those nodes. So to try to get them to kind of see all that, it was hard, and they kind of they got kind of desensitized to it because it was so much work and there was so much disease that it was easy to miss the small ones. One other problem is extranodal disease. So there was a question somebody asked: did we label all the disease? We tried, but there's extra. So when patients have lymphoma, they have disease in the lymphatic tissues. They also can get disease outside of that, like in the lung, in the liver, in the bone marrow. And it's challenging how to handle those cases because sometimes they're treated differently. Sometimes they're treated with lymphoma, the same with lymphoma. So we kind of, in our problem, we ignored those, knowing that at some point we're going to have to deal with that. And I think everyone's going to struggle with that, is how to deal with extranodal disease in measuring MTV. Common sites of error: the ureter, the kidneys, the tonsils, those ones were troubling. Brown fat, as I mentioned. And then we also found that below the diaphragm is harder than above the diaphragm. Below the diaphragm, it's kind of messy in PET, right? You have the ureters, you have the bowels, things look different a lot. So below the diaphragm was harder. And then the last pitfall is, the question that everybody has: do we have enough patients? How many subjects do you need to do well? So we did this analysis, and you can't really see this very well, but essentially what we found was that training our algorithm with 20 patients or 30 patients, we got about the same results as if we trained it with 70 patients. So, which was interesting, right? So you don't need all those patients. What I think happens is at some point you get diminishing returns with the number of patients you have. And what becomes the critical component is the accuracy of your labels. So there's this nice study from the Google group. Sorry, the names kind of got lost there. But this study showed that they got accuracy with, so this is number of training data sets, and you can see it plateaus. But then they showed the number of grades per image, meaning the number of people labeling, which is essentially mean the accuracy of the label. They got better returns with more accurate labels than they did with more images. Hope that makes sense. But at some point, the number of images don't help you, and you really got to focus on the accuracy.
Tyler, is your network pre-trained?
No, we did not pre-train it.
Okay. And also, can you explain why this curve on the right at the top, what does it mean to have 100% training set? Is that like a reference? Or
yeah, that just shows that their training was matching exactly. So when you train an algorithm and you evaluate the accuracy on your training data, they got about 100% on their training data, but on their tuning data, so their validation data set, you can see it wasn't perfect until they added more labels.
And so the consistency somehow makes the performance better.
Yes. Yeah. So if you have more accuracy, because what you think about, if you have inconsistent labels, I think the network doesn't know what to do, right? It gets to the point where it goes back and forth, not knowing how to, label a certain image.
Yeah.
And I think it's an important point, is that, I think if we were to build on the study, I wouldn't go looking for more patients. I would go to try to find better labeling.
That's a very good point.
Yeah. I have a question, a follow-up question on that too.
Yeah.
Would the number of patients also depend on the heterogeneity of possible markers?
Yes. So yes, the number of patients that you need is very dependent on the heterogeneity of the problem you're trying to solve.
Right, exactly. So how would the example that you're giving, which is very interesting, fit in that additional degree of freedom set?
Yeah, so I guess it's a hard question, because every problem whenever you tackle a problem, you don't know how heterogeneous the problem is to a network. So for example, I had another problem where I was trying to convert MRI images into CT images in the head. I only needed a few patients. I only needed like 5 to 10 patients because that's very consistent.
Right.
Every patient's head looks the same about. And so, but if you're trying to say, classify a building from a truck, you know, those can be quite heterogeneous. The appearance of a building, the appearance of a truck, and you would need a lot of data, maybe thousands, hundreds of thousands of data sets for that. So in PET, I think we don't know quite where that number needs to be. We don't have a feel for it. But in this case, in lymphoma, I'm finding, you know, maybe around 50 subjects, you know, 50 to 100 in that range is probably good if you have very accurate labels.
Okay, thank you.
If I may add a comment, and also, so I missed that. So what's the fewest number of subjects you were able to use?
5.
Just 5. Oh, wow, okay.
Which is this bar right here. You can see the accuracy.
I see, okay, right. And my comment would be that, you know, with such low number of training samples, you may just get like features, you may learn features that are on the surface in the image, and it will kind of get you to the AUC values that you were, like the ROC curves that you were measuring. But to get to that physician level, you know, who knows how many images will be required, right? So you may find yourself being like on the precipice of an exponential in terms of the sample complexity.
Yeah. Yeah, it's a good point, right? Like maybe if I had 1,000 patients, you know, it's going to level off, but it may still keep going up, right? So maybe if I had 1,000 patients, I would have really good results. But is that worth, you know, the effort to get that extra percent? It depends on the problem you're looking at.
Yeah. Yeah, it depends on the importance of accuracy, or false positive, false negative, respectively.
Exactly. Exactly.
As I understand, you were using patches. So although you had 5 subjects, you might have had, you know, thousands of patches that describe different, you know, variability of different lesions and so on.
That's very true. Yes. Yes. Okay. So, all right. So that's what I'm going to show for the detection problem. As I said, we split this problem up into detection and then measuring. So the second step is once you detect a lesion, so we feed the image, we have the lesion, then we have to segment it. So then we did some work on lymphoma segmentation in PET, which really there's not a whole lot of studies on, surprisingly. I think it's because it's not a commonly, you know, segmentation is usually done in radiation therapy, and it's not one that it's often studied in radiation therapy. But we looked at how to best segment the lesion. So we took these same patients that the physicians contoured, because we asked them to contour it carefully, which is another reason why they weren't very happy by the end. But then we applied 11 segmentation methods, which included thresholding of the image, iterative thresholding, active contours, clustering, and then at the end we have 2 deep learning ones: DeepMedic, which is the patch-based 3D one, and UNet, which I believe this is actually a 3D UNet that we implemented both, and I think we picked the 3D one. And then, so what's shown here is the green is the ground truth for the physician, and the red is how well the algorithm did. And so we evaluated these 11, and here's the results. So what we have on the top left here is the dice coefficient, which describes the accuracy of the contour. And the top method was actually our DeepMedic, the 3D patch-based method.
I have a question for you again.
Yes,
that
go ahead.
one also has the highest standard deviation. So even though the mean is a bit higher, when you worry about the standard deviation.
Yep, that's exactly right. So it's an interesting case, right? Because it has the highest values, but also some of the lowest, right? And so it was very interesting. What's even more interesting to me is that the number 2 method is iterative thresholding, which is pretty simple method. I don't remember exactly which one this iterates on. I think it's the volume of the tumor as it does a threshold, but it's very easy to implement, and it gets, you know, almost as good as DeepMedic. as a 3D convolutional network. And what's surprising is that the UNet is at the very end. For whatever reason, we couldn't get the UNet to do as well as DeepMedic. And now, granted, it's not doing terrible, but it just wasn't doing as well. One interesting thing down here, though, is if we look at the volume measurement, we can see that DeepMedic is actually one of the better ones, actually the best in terms of this standard deviation.
Sorry, what do you mean by?
Sorry, go ahead.
Just very quick. What do you mean by relative volume difference exactly?
This means if the physician measured a volume for that lesion, right, based on their contour, and then the algorithm measured a volume.
Thank you. Yeah.
So I was wanting to ask, where's physician 2 on the x-axis?
That's a good point. I don't think we don't have that in this graph, but this paper actually just got accepted for publication a couple days ago. So this will come out in Physics and Medicine and Biology, and I don't remember exactly where physician 2 lies on this graph. It's a great question, though.
And just another quick one. So the cases where we see dice almost 0, so was that kind of like a complete failure of the segmentation for that particular, ROI or?
Exactly, yes. So let's talk about the pitfalls.
Tyler, can I ask you a question before you go?
Yes, yes.
Okay. Coming back to the previous slide, have you ever tried, for example, okay, because we know the iterative method is easy to implement, but you need to kind of click somewhere so that it does the threshold around that.
Mm-hmm.
Have you ever tried doing DeepMedic and then to those results applying the iterative one?
Yeah. So that would be the idea, is that we would do DeepMedic to detect disease, plant a seed, and then use another algorithm to segment. And so it could be any of these. So you could actually have 2 DeepMedic models trained to do different things, or DeepMedic fed to iterative thresholding. Yeah.
And if I may ask another question, so how was the dice coefficient measured? Was it measured using a combined segmentation of all lesions in the image, or was it per lesion?
Per lesion, which is actually a point I'm going to get to in a second, because that's where it gets to be complicated. Yeah, but it is per lesion. So pitfalls. You can't force a CNN to segment something. That's why we had a bunch of zeros for the UNet, even some of the other algorithms too. If you feed it a patch and you say segment the lesion, it may spit out nothing and say, I don't see a lesion. So that's a problem. I think there's ways around that, but out of the box CNNs, a lot of times they're just going to say no, like my 4-year-old, just going to say no. The other problem is it's kind of a mess to deal with overlap between patches. So you could measure the dice across the patient, but we looked at it on a per lesion basis. And in lymphoma, there's clusters of lesions. And so you might be looking at one lesion and your bounding box may have a few other lesions in there. It's kind of a mess to deal with. And so just, I guess, a warning for any of you who are going to attempt this, it's worthwhile thinking that out. Okay, so now I'm going to move on. So we talked about detection, then segmentation, but another approach is to just automatically segment, right? Automatically segment from the image and then quantify. And so that's what I'm going to talk about now. So bypassing kind of the detection segmentation step and just going straight to segmentation and measurement. And so this work, again, performed by Amy Wiseman, was we switched data sets here to a pediatric Hodgkin's lymphoma. So this is a data set acquired by the Children's Oncology Group, where it was a multi-center trial of high-risk pediatric Hodgkin's lymphoma. And it was 100 patients that had baseline and follow-up imaging. And so what we did is we had 2 fellows go and segment disease using PET thresholding methods. And to be honest, this was just so that we could quickly analyze the data. It was actually segmented for another purpose, which we then repurposed for our AI algorithm. And so what they did is they did different thresholding methods where they threshold all the disease and then kind of delete the ones that are not disease, if that makes sense. So you threshold it and you get all this normal tissue and disease, and then you delete the ones that are not diseased. They did 2 thresholds, and we just did a union of those as our training algorithms to define the boundaries, and then we used that to train our algorithm to automatically detect and segment the disease. And so we use the same model before, the deep medic model. Again, it's a favorite of mine. And these are the results we get. So some example images showing the physician in the green and the the deep medic method in magenta. You can see we get pretty good results. In fact, we got better results in brown fat because these pediatric patients have a lot more brown fat than adult patients. So the network learned better to how to deal with the brown fat. And now our goal was to quantify. So what does quantify mean? That means usually we're trying to measure metabolic tumor volume, or we can also measure SUV max, which is often used in PET imaging. So here we show the correlation coefficients between the automatic method and the physician measurement, and the correlation coefficient. You can see we get really good results. Now, one thing about SUV max is because SUV max is the maximum pixel in the tumor, you should be able to get that 100%, right? You should be able to get an R of 1. So any deviations from that means that we weren't picking up the same lesion in that patient as the maximum lesion. So these outliers were usually caused by ureters and kidneys. But MTV, we got pretty good results. But there are, of course, some pitfalls in this study. Same problems as before, right? I mentioned those same organs that cause problems. One problem is if you look at this, this lesion here, so this is the spleen and liver. The physician just said the whole thing was one lesion, right? Because there's disease spread throughout it. Our deep medic method split it up, right? It didn't measure all of it. And this has a huge impact on the MTV. This was quite a large outlier. You see it's kind of the same thing here, where the physician contoured a big cluster of disease, whereas deep medic split it up. And these kind of problems can have a big impact. One interesting thing is that this model was kind of, every epoch it was training, it would cycle between contouring the whole tumor or the whole spleen and liver and not. So sometimes it would do the whole thing, sometimes it wouldn't, just based on epoch. It would cycle back and forth, and we just happened to end on the one where it didn't, which is an interesting thing. It was clearly confused on how to handle that. Some other pitfall is that while we can measure SUV max and MTV, other metrics, so those 2 metrics are actually pretty robust to your method. If you get the bulk large disease, you're going to be fine for the most part. But there are other metrics that you may be measuring that are not robust. So this is one measurement that we noticed. It's called Dmax patient. It's a metric that actually measures the distance between the furthest distance between lesions in the body. So it's a distance metric, because they think if you have disease in 2 faraway parts of your body, you're going to be worse off. And this study kind of shows that. They showed a couple of studies. So we wanted to see if we could reproduce this measurement, and we couldn't. This is the correlation plot. It did terrible, because one small false positive or one small false negative can give you a totally different Dmax. So even though you can quantify one thing well, it doesn't mean you can quantify everything well. It's just something to be aware of.
Also, can I ask you a question related to this slide?
Yeah.
What you earlier said, so in this example, in the top part on the right, you said to the neural network either segmented everything or or parts of it.
This, yes. Yes.
So would you say it was like a bimodal behavior almost?
It was. I mean, in this case, for this specific patient, we looked at how it segmented versus the number of epochs we trained it, and it was going back and forth. So it was oscillating between them.
And so this may be related to the number of subjects that you're using for training. And I wonder if you have looked at the effect of the number of subjects on this behavior in particular.
I have not. No, we did not do that in this study.
Okay, thank you.
Yep. Okay, so let's move on to PET image classification. So in this case, what we've done was image analysis. Now I want to talk about classification. So the difference being that we're not trying to measure something in the body. We're trying to look at an image and apply a classification to it, a label to it, like responder and non-responder. The reason we want to do this is because we've talked about MTV, which is not used clinically yet. But one thing that is used is Deauville score. So the Deauville score is on a follow-up scan. It gets a score from 1 to 5, depending on how much residual tumor there is following treatment. And the 1 to 5 depends on how much uptake there is in the tumor relative to the blood and liver. Now, this Deauville score is actually applied internationally to almost all patients who are followed with PET and lymphoma. It's a very useful metric. Some phase 3 study just came out showing that it actually improves survival in patients to treat based on the Deauville score. The problem is that follow-up scans are a lot harder than baseline scans because there's a lot of different things that can happen. There can be reactive nodes, so lymph nodes that light up because of treatment but aren't actually progressing. There can be bone marrow that gets lit up. The disease is much more subtle. So in baseline, the disease lights up like a light bulb. At follow-up, it's much more subtle. And you also want to know about where the disease was at baseline so you can see if it's there at follow-up. So it's a much harder problem. So looking at these two images, if you read PET images, trying to decide which one's a responder and which one's not, it's actually opposite of what you might think. I look at it and see these little hot spots. I think, oh, that patient's not responding. But those are actually explained by some things in the patient's history. And this patient looked pretty fine, but I think something in the neck here is still hot. So it's a lot harder, a much more subtle problem. And so we wanted to tackle this. We actually did two approaches. We used this same Hodgkin's pediatric lymphoma data set. We had two fellows assigned Deauville scores, and we wanted to try to replicate it. So our first approach was kind of a physicsy approach, I'd say, where we actually took the baseline image of that patient and the follow-up image. We fed them both, and bear with me here. It's a kind of a complicated if you look at the plot, but each step kind of makes sense if you're going to do it yourself. So we took the baseline, we fed it through a CNN and got where the disease is. We also took the follow-up and fed it through a CNN and got where the disease is. Then we wanted to see if there's overlap between the baseline and the follow-up. So we registered them together. And then ideally, we would just take this and say, okay, wherever there's overlap, that's disease, but that didn't work very well. So we did kind of a radiomics approach where we fed it to a support vector machine and then got the final labels. And then from there, we got our Deauville score. We applied it, we created a Deauville score. So again, a little complicated, but I guess kind of intuitive if you're gonna go through the process. And how well did we do? Actually pretty well. So we got our 5-class Deauville score accuracy was 61%, which sounds bad, but the two individual physicians had an agreement of 60%. So pretty close. And actually, if you look at the kappa score, we had a kappa of 0.74, where the physicians had a kappa of 0.78. So we're actually pretty happy with how this came out. Ideally, we would get better labels and less disagreement amongst physicians. But we were able to pretty much get within that range of inter-physician disagreement. And our goal is to now, this is 100 patients, is to validate this in a larger data set from the Children's Oncology Group.
So Tyler, I might have missed this, but the Deauville score you could do on a given PET, but you're looking at both the baseline and the follow-up to clarify that? Okay. So you're measuring the difference between the two?
So we're measuring the disease on both scans, and then we're registering so the problem is on follow-up, because the disease is so subtle, you get a lot of these false positives. Yeah. So the registration kind of helps regulate this, right? Regularize the follow-up.
That makes sense. Yeah.
Are you registering the CTs or the?
Yeah. So we register the CTs and then apply the transformation to the PET. Yeah. Approach 2 was actually just throw a lot of data at it. So what I did, I'm gonna speed up here because I'm almost out of time, is I just essentially, I looked in our PACS system and pulled all the subjects we have with lymphoma that have Deauville scores, and then trained a CNN to classify it. So I actually took the 3D PET images and collapsed them into 2D maximum intensity projections, mostly because the 3D one didn't work as well as the MIPS, which is surprising, but I guess not totally surprising with 3D networks. And I just took all the data from PACS. I took the radiology reports. I did some natural language processing to pull out the Deauville scores. And then I trained an efficient net CNN. And what we found is that I had 1,700 patients with Deauville scores. And in the test data set, which was 250, we got an accuracy of 85%. Now, what I did is I didn't do the 5 scores, Deauville 1, 2, 3, 4, 5. I split it into 1 to 3 versus 4 and 5, because those are usually how you split them into responders and non-responders. But this is about the accuracy. This is about the accuracy that our last method got as well when you split the data. So it was very interesting that we could just pull this data from PACS and get almost the same results as we got previously with a much more complicated method. And then one thing I also did was applied this kind of explainable AI method, which does iteratively zeroes out patches in the image to try to find which ones influence the classification. And I can see, using this method, I could see that the network was struggling with, well, kidneys, right? And brown fat as well, which is no surprise. You've probably heard that several times now. But I found this pretty interesting to be able to apply these methods to look at explaining why the network is failing. Pitfalls of image classification. Actually, I'll probably just skip this. I'll just say that sometimes the network learns things that you don't want it to learn. I don't have any evidence that this happened in our case, but it's something to be aware of, that if you have something that kind of gives hints, say where the scanner, which scanner it was taken on and so forth, it can throw off your results. All right. Are there any questions? Okay. I'll move on to image reconstruction. I'm going to go through these ones pretty fast because I think it's exciting. I don't do reconstruction, but I think it's going to be an exciting area because lots of people are working on it. Here are several papers. GE has a deep learning image reconstruction engine. I think it's exciting, but I think it's going to be really hard. And I think it's something that we all need to kind of pay attention to, the physicists in nuclear medicine. Because you got to remember that a sinogram, a time of flight 3D sinogram, has billions of elements, right? And these billions of elements are going to be fed through a CNN. That's asking a lot, right? This is going to be a huge network. And so there's going to have to be shortcuts taken to make this work. The paper that I've seen that's done really, that's done a really good job is this deep PET paper, where instead of using 3D sinograms, they broke it down into 2D sinograms using rebinning, and then reconstructed low resolution, which is 128 by 128 PET images. What I like about it is that they used phantoms, simulations, and patients, and then they got decent results with it. So the results here are shown in this plot, where you have the bias on the y-axis and the variance on the x-axis. And the goal is to be in the bottom left, right? And their method was right here, where the clinical method is this orange. So you can see they get a lot better results, which is exciting. But again, these are low resolution. You're throwing out the 3D information. You're throwing out time of flight. So I'm interested to see where this goes. What we've worked on is actually doing denoising, which several people are working on. In fact, there's this company, Subtle Medical, that actually has a commercial product for denoising PET images, which is exciting. The work we did, I worked with Scott Wollenweber at GE. We tried to take good quality PET images, which is this 1 minute 30 acquisition. So it's a 1 minute 30 scan time, and tried to reproduce 6 minute scan times, right? So these are high quality images because you have more counts. And we applied different models to it to see if the model mattered. If you did a complex model like the UNet or DeepMedic, versus a very simple model. This GE model is about as simple as you can get for a CNN. And it didn't matter, right? I think what happened, and somebody mentioned this earlier, is, you know, depending on if your problem's really heterogeneous, you need more data, more complex models. I think this is a pretty simple problem. And so the simplest model did just as well as the complex models. But one problem that we did find is that even with CNNs, if you apply this kind of filtering, which really this is what you're doing, we did lose SUV values. The SUV max went down by 15%, which is not ideal. So what you want to be able to do is preserve the contrast while reducing the noise. And we weren't able to do that successfully.
Right. I recall hearing even from Scott himself that it was somewhat over smoothing.
Yep. Yeah, I think there are ways around that me and Scott have talked about, like using gates, which is kind of what they do in NLP, is use these gate nodes to kind of pass through the original values. But yeah, if you're just going to use it out of the box, it's going to reduce the contrast.
I think it must be related to the fact that all these networks have some sort of feature compression going on, you know,
Yes.
and
Yes.
and so these contrast values will just get marginalized.
Yes. Yes, I agree. Right, that's what's happening. Right, there is a compression. It's and then it's trying to recreate the values, but it's not going to get exactly what it was. But again, I think there are ways around that. So let's talk about pitfalls after you've watched Homer fall off the cliff multiple times. One of the things I worry about with reconstruction are hallucinations. So really why I want to talk about this is because I think this is a problem that people don't appreciate, is that networks can hallucinate. And what that means is they can produce features that don't belong in the image, but that the network has seen previously. So this is an actual example where somebody was denoising using a commercial product, I think from Google, and their image came back with Ryan Gosling's face in it. Which, you know, I mean, our problems won't have Ryan Gosling. We don't have Ryan Gosling in our training data set. But I mean, this just shows you the problem of what can happen. And the problem is that these features can have a big impact on the interpretation of the image, but they could be really hard to quantify. If you're just looking at correlation coefficients or other metrics to say how good is my denoising algorithm, you might miss these hallucinations. And actually, if you look at this study that I talked about, the deep PET reconstruction here, this was the original on the left and the deep PET on the right. If you look carefully, you can see what I would call some hallucinations. Things that I don't think really are in the original image. At least they weren't in the OSCM and the filter back projection image, right? Some of these things, it almost seems like it's making up. One thing is to look at the skin. In PET imaging, the skin's always hotter than the fat that's underneath it. And this algorithm just completely ignores that, which may be because it was trained on some simulation data. So I guess what I want to get out there is that we need to look not just at numbers of correlation coefficients, but look at the images and see if things are, you know, getting added to the images that shouldn't be, because it's totally possible. All right, I've got just a few minutes, so I'm going to quickly run through attenuation correction. The reason I do this is because this is where we've been the most productive at University of Wisconsin. So the problem with attenuation correction is that in PET, the photons originate from inside the body, but the ones deep inside the body are going to interact with the tissue on the way out and not get detected. So that's called attenuation. And so if you don't correct for that fact, you'll have a lot of photons making their way outside the body on the edge, but not in the middle. And so this is a attenuation correction, and we usually use a CT scan, which has electron density information, to correct for the phenomenon. But in PET-MR, we don't have electron density, we have proton density. So it's a problem in PET imaging that we need to essentially take an MRI scan and get a CT scan from it. So we approached this, actually in 2017 was the year of attenuation correction for us, because we started the year with just talking about, hey, I brought up to my actually office mate at the time, Alan McMillan, said, hey, we should do attenuation correction with deep learning. And we got Young Suk and Fong involved, and within a month we had a solution that we submitted to a conference. A month later, actually I had a baby in that time. A month later, we got another paper. We got a paper submitted, and we got another paper, and then another paper, and then by the end of the year, we had submitted an R01, which got funded, and then another paper. It was really exciting to see how quickly you can, if you have the data sets, how quickly you can solve these problems. What are the things we did? We converted MR images into CT images. We converted non-attenuation corrected PET images into CT images. Those were both in the head, and then we did it in the pelvis as well. We got good results. Right now, well, we got the R01, so now we're still working on this problem. Right now, we're working on trying to get 40 CT images from 40 PET images. So synthesizing 40 motion CTs from motion PET images so that you can solve the problem of the mismatch between the two, which can cause under attenuation of lesions, under correction of the lesions in the dome of the liver. And here's some example results of what we're doing. These are we're still working on this problem, but you can see the problem where you have an under correction of the liver here. And then when you use the AI algorithm, it solves that problem. So there we go. That's the stuff I wanted to show you that we're working on. Again, Armand, I think you were most interested in the lymphoma, so hopefully that gave you kind of an idea of the stuff we've done and are working on, as well as those other things. So thanks for listening, and I guess I can take any questions.
Yeah, thank you, Tyler. That was really fantastic. In fact, 2017 is a year I really got to know you guys, actually.
Yeah.
So I remember that. It was a great year for you guys, and yeah, so that was great, and thank you very much. This was great. Any questions, any thoughts?
I do have questions, and again, thank you for the talk. It was absolutely spectacular.
Thanks.
So we have the same scanner as you do, but we do brain imaging. But with Armin, we'll start to do some whole body imaging. So I'm really curious to know more about your attenuation correction and what was the key feature that made it work.
Yeah, so I didn't put a pitfall slide, even though I was tempted to, on the attenuation correction. But the pitfall for attenuation correction is the registration of the CT and MRI for ground truth. So you need to train an algorithm having matched MRI and CT images. But in the head, that's easy. In the pelvis,
right,
it's okay. In the chest, in the abdomen, it's really hard.
So how did you do it? Did you do it for each patient, or how? I mean, that would make sense. So how did you do it?
Yeah, so we have not solved the whole body problem yet. But for the head, we did registration, and the pelvis, we just did registration with manual adjustments. So I kind of manually adjusted some of them. In the body, it's one method that I've used recently is going through hundreds of cases and finding the cases where there's good registration, because most of the time there's not. And you don't see this in the papers, but often the registration algorithms aren't great for MRI.
Yeah, I know.
Yeah.
Well, that's why it's always good to talk to people as opposed to just reading the papers.
Right. We always put on our best face for the papers, right?
Yeah.
Everything
so
worked great.
Pelvis, you said it works well.
What was that?
For pelvis, you said it works well.
Pelvis, we got good results, yes. And there are other people who have done that as well, who have come out with work in the pelvis. And that's just because it's kind of rigid, right? For the most part.
Now, how much does that depend on the particular CT you're using? I guess where I'm going is how portable are your training data sets or your algorithms now once being trained?
They're terrible. I mean, I wouldn't trust it at all in somebody else's. And it's not because of the CTs, it's because of the MRIs. Your MRIs might look very different than my MRIs. Even if we have the same scanner, I don't know, maybe if we harmonized our image acquisition.
Because that would be a fun thing to try, given we're starting to do this as well.
Yeah, I mean, we are collecting large data sets. So Alan McMillan is the PI on the project.
Yeah.
We are collecting large data sets, and we plan to share it.
Perfect.
We plan to share it with people. So, so if you want to get involved in that, I think we'd be happy to send you. Right now, we have, I think, about 50 head cases where we've acquired multiple sequences.
Yeah.
over the head, and now we're working in the body as well.
Happy to collaborate on that. Very happy to collaborate on that.
Yes.
And I guess I'm speaking for Arvin as well, right?
Absolutely, yeah. It's yeah. There's actually a related project where we're working on with Gaston's group also. This one, Tyler, you might have heard of, where started with the work of Isaac, who basically took the reconstructed non-attenuation corrected PET image and basically produced attenuation corrected PET image. So not even looking at the sinograms, just looking at the final image. And we were again very surprised, hard to believe that it actually worked. And then we extended it to whole body. And now again, we're trying to work with Gaston's group, you know, to looking at with a member of his group, Saeed, who's really trying to further improve these things. So again, not looking at sinograms, going all the way to the end.
Yeah. So skipping so essentially reproducing the attenuation correction through your CNN. Yeah.
Yeah.
Yeah, we've dabbled in that as well. The nice thing about that is that you don't have to worry so much about the registration, right? You can assume the CT does a good job, so you don't have to, the processing isn't as intense.
Yep. Yep.
Yeah.
I had a question about the reconstruction you were doing with AI.
Mm-hmm.
You were showing going from a 1.5-minute scan to like 6 minutes, right?
Yeah. Yeah.
I'm wondering, what was the partial volume effect that you saw? Was it, and like, how did that compare to something simple like just Gaussian smoothing?
Yeah. So let me think how to answer that. So we didn't compare it directly to Gaussian smoothing, or that's not true. I think Scott Wollenweber, the engineer from GE, actually did go ahead and do that. So we preserved more contrast with the deep learning method than Gaussian smoothing. So for the given level of noise, the deep medic method was, or the machine learning method was better, but it did do, smooth out the image, right? So you lose the contrast. Now the partial volume effect, I guess it's hard to compare partial volume to Gaussian smoothing, because the partial volume effect is going to be the same in the 90-second image and the 6-minute image, because it's a partial volume is a function of the spatial resolution, not the noise. But I don't know if that answered your question.
Yeah, that's helpful. Thanks.
Okay.
I had a question. So in the ensemble of deep medics, so you said you had three models that were trained.
Yeah.
So how exactly were they different from the start? In other words, what was the difference between the three models?
Yeah, all we did was randomize the weights and training order, and that's it.
Okay.
Exactly same in terms of architecture. And you know, I got this idea. I went to the McKay conference one year, and I was talking to some people from Google Brain, I think it was, and they were kind of, we were just at a lunch table talking, and they said that that's kind of like a dirty secret that a lot of people don't tell you, is that sometimes they will train their model and use ensembles to report the results, which to me is not the right way to do it. But maybe if you work for a company, that's the way you do it. So that's kind of where I got the idea, is just train your model multiple times and then take an ensemble.
Well, I think it's related to the winning lottery ticket theory. Is that basically the networks that we use are over-parameterized, but you can and you will never get to the absolute global minimum of your cost function, but you can get close to it by just permuting initial weights and biases to kind of increasing your search space, and it will depend on where your model eventually converges to.
Yes.
By using multiple iterations or multiple realizations, you can kind of, try to get closer to the global minimum.
Right.
So from that point of view, that's kind of like almost, that's perfectly reasonable to do it, I think.
Yeah, I agree. The question is 3 ensembles, an ensemble of 3 the same as if you train the model 100 times and pick the best one. You know, that's what I'm not sure, because if you train the model 100 times using different weights, it's going to converge to a different minimum, and maybe closer to the global.
Right, but then you'd also
or there's something in the ensemble that is actually better than that.
I think when you're forced to choose a single model, you will have to look at your validation set, not your test set, right?
Yes.
And so the validation set, it does not represent your test set. So picking the best model on the validation set does not necessarily guarantee picking the best model overall.
Yeah, that's true. That is true.
Okay. All right. I think, Tyler, this has been fantastic. Really appreciate your time. It's a pleasure and I'm really grateful that you agreed to give a talk to us. So thank you. Thank you again. And thank you everybody for attending, and have a great day.
All right.
Thank
Thank
you.
you.
Thank you very
Thank you.
much.
Take care. Bye.